All right, thank you very much for the opportunity to present at SAGES, and thank you to the few of you who have stayed around till the final presentations. But today we'll be talking about outcomes between minimally invasive and open distal pancreatectomy using a matched cohort from the NISQIP database. Our authors have no relevant disclosures, and none of these views represent the views of the Army or the DoD. So just a little bit of background, minimally invasive distal pancreatectomy has been described for several decades now, first by Dr. Cusciari in 1994, but there's no high-level evidence besides these two small randomized controlled trials, the LEOPARD and LEPOP trials, comparing outcomes between open and distal pancreatectomy. And these RCTs did show that there's a decreased length of stay and improved quality of life for the minimally invasive distal pancreatectomies. But, and while they didn't show any differences between complications, in these studies, they also were not designed to examine that question and not powered to do so. So there's been many retrospective studies that have examined complication rates between minimally invasive and open distal pancreatectomy, but we're really comparing apples to oranges with these patients. There's a lot of patient selection bias when you're deciding which approach you're going to use for these cases. So with our study, we wanted to try and control for that and use a matched cohort to look at these 30-day complication rates, mortality, and pancreatic fistula. So using the NISQIP database pancreatic file, we looked for all patients who underwent minimally invasive or open distal pancreatectomy from 2014 to 2018. This included with or without splenectomy, and these were only elective and non-emergent procedures. And we excluded any patients with the extremes of metastatic disease, ASA class 5 and class 4, or pre-op sepsis or ventilator use. For our primary outcomes, we looked at a composite major morbidity score, meaning claving and dindo class 3 or 4 complications, mortality, and then the postoperative pancreatic fistula rates, which we defined as either labeled as grade B or C pancreatic fistulas within the database, and we also included those patients that had drains removed greater than 21 days or interventions including percutaneous drainage, and NPO status with TPN, reoperation, or spontaneous wound drainage. Secondary outcomes we also examined were 30-day reoperation, readmission rate, delayed gastric emptying, and length of stay. So for our propensity score matching, we used a method, a genetic match method called Mahalanobis distance matching. And the explanatory variables that we thought could explain the differences in our cohort were a benign versus malignant pathology, age, sex, BMI, smoking status, and other preoperative factors such as their functional status, whether they had preoperative weight loss, and then also if they were receiving any neoadjuvant radiation or chemotherapy. We compared the groups with a covariate balance assessment and identified any of those with a standardized mean difference greater than 0.1 to use in our matching algorithm, and then did the balance assessment again to make sure that we had adjusted correctly. And then we looked at the outcomes both before and after matching to compare. So within our study, we had just under 2,000 patients in each cohort before we matched. And before matching, when you compare the groups, you do see there is a selection bias. The patients in the minimally invasive group have less malignancy. They haven't undergone neoadjuvant radiation or chemotherapy. They have higher BMIs, lower ASA, less weight loss, and fewer bleeding disorders. And then after we performed matching, our cohorts in the open group shrank down to about 1,000. So this just shows those standardized mean differences, and as you can see in these top categories, the dashed line showing before matching that things are very unbalanced between the two groups, and then after we perform the genetic match, the weighted group swings over to be more similar and have less mean difference. So comparing our overall outcomes, so no differences before or after matching in the composite morbidity or mortality, but we do see that there's a higher rate of postoperative pancreatic fistula within the minimally invasive group once you match, which we don't see before the matching process. And then no differences in reoperation or readmission, But delayed gastric emptying is known to have a lower rate in minimally invasive distal pancreatectomy, and that difference goes away once you control for the preoperative factors. And then, as expected, the length of stay is, of course, shorter for minimally invasive distal pancreatectomy, regardless of matching. So looking at the odds ratios for these outcomes, pancreatic fistula was about 40% higher within the minimally invasive distal pancreatectomy group once you compare a matched cohort. So in conclusion, once you adjust for these preoperative characteristics that contribute to selection bias in choosing your minimally invasive group, you see a higher rate of postoperative pancreatic fistula in the minimally invasive group compared to open, and despite there being a shorter length of stay and having equivalent reoperation readmission rates. And this just continues to call into question the techniques that we're using for minimally invasive distal pancreatectomy, and that we still need to have some work to do to come up with the best technique to prevent these pancreatic fistulas. Thank you. I'll take any questions.
Good.